Hello, everyone. Welcome to Meetings on Demand. My name is Rob Beanlands from the University of Ottawa Heart Institute. My disclosures are that I have research grants and honoraria support from Jubilant Draximage, from GE Healthcare, and from Lantheus Medical Imaging. This multimodality session is focused on advanced cardiac imaging of cardiac sarcoidosis, how to choose better. This is a pre-recorded session. You can send questions, if you have any, to annualmeetings@asnc.org, and we will forward these to the speakers, and they'll be able to respond to you directly to answer your questions. Our first speaker is Dr. Raymond Kwong, MD, MPH, who will be presenting on the role of MRI in cardiac sarcoidosis. Dr. Kwong is the Director of Cardiac Magnetic Resonance Imaging at the Brigham and Women's Hospital and Professor of Medicine at Harvard Medical School. Dr. Kwong directs the clinical CMR program at Brigham and Women's Hospital with a focus in training cardiologists and radiologists to perform and interpret CMR for the management of various cardiac conditions. Dr. Kwong?
Hi, good afternoon. I am Raymond Kwong from the Brigham and Women's Hospital in Boston. I thank the American Society of Nuclear Cardiology for inviting me to speak on this topic on cardiac MRI for sarcoidosis. This is my disclosure slide. I have no relevant disclosure. So why use cardiac MRI in the management of cardiac sarcoidosis? In the way of background, I think there are several important points. That this is a disease that patients often present with non-specific symptoms and signs, but it's a potentially lethal condition given its affinity with sudden cardiac death. And cardiac sarcoidosis, CS, has many different patterns of myocardial fibrosis, and this is the point of confusion sometimes when it comes to the ability for MRI to diagnose the condition. And I'll show some examples to illustrate that. There's no clear unique signature of the myocardial infiltrative pattern by CS. CS has different physiology of interest because of the mode of the current intervention, the options of current interventions. We need to characterize not only the scar, the fibrosis, but also the severity of inflammation. And that is what cardiac MRI and also PET aim to characterize. So in light of all these come at other challenges that there's currently no gold standard for non-invasive imaging to compare against in diagnosing the disease. So we have to rely on criteria such as the Heart Rhythm Society criteria or Japanese Circulation Society criteria, which have improved over the years, but by no means they're perfect gold standard. This is also a fairly rare condition, making it hard to perform a prospective trial to study the different treatment options and randomize patients. So given all these, we need to not only diagnose the condition, but also develop ability to monitor for disease activity so that we can monitor the effectiveness of the therapeutic response so that the non-invasive tool ideally should be able to scale the overlapping risks between fibrosis with its propensity to heart failure and arrhythmia and inflammation. And also, suffice to say that the ideal non-invasive tool can also quantify the pathophysiology and is very reproducible. And it's important that the non-invasive tool has a fairly highly standardized protocol that can be applied across different centers. So it has been more than a decade, maybe a decade and a half now, since the original description of how LGE imaging, as shown here, in white in this imaging, and the white part demonstrates the area of fibrosis, has been associated with area where sarcoid affects the myocardium with fibrosis surrounding non-caseating granuloma, as shown in here. And that's how MRI primarily use LGE imaging to target the focus or foci of myocardial infiltration. Of course, this is not a specific entity at the tissue level to characterize non-granulomatous changes. But however, MRI with the standard technique, the LGE, being a high-resolution method with a ability to capture in-plane spatial resolution at 2 millimeters and has high tissue contrast to detect not only the scar tissue or infiltrated tissue, it can also look at live tissue. With that kind of tissue contrast, MRI has been shown to be a very effective tool to identify the different causes of cardiomyopathy. I won't go into the detail of this slide. I'm sure you have seen this sort of work before that show that the different patterns, whether it's multifocal or epicardial, or whether it thins out the wall, these patterns have been described in various types of cardiomyopathy. The ischemic one tends to be infarction that tend to affect the endocardium, whereas the non-ischemic pattern happen in different types of cardiomyopathy and so forth. So in most centers are using the standard LGE method, which has been around for almost 2 decades now. And it's pretty much the same that, as I mentioned, that it involves an inversion recovery pulse to suppress the myocardial signal and bring out a contrast, the infiltrated or scar tissue, as shown here. And whether it's sparing the endocardium, the pattern of that, and in the location, and whether it is multifocal is what we describe. In more specialized centers, there's an increasing trend of using dark blood LGE method, which is a technique to suppress the signal from the blood pool itself, and therefore the myocardial LGE can be brought out in on top of the background of black signal in the blood. In more advanced centers and more experienced centers, some centers have also been using a navigator prep whole heart 3-dimensional method, which the implication of that is it can drive the in-plane resolution down to about 1 millimeter, and you can detect sort of smaller lesions and possibly increase the sensitivity of the scan. Now, MRI is not just about doing the LGE, but every scan should be correlated against matching segments of function. So here, this is an example from American Heart, from circulation from a few years ago, from a number of years ago. It showed that as patient of sarcoid with an increased wall thickness here, infiltrated, expanded wall, which matches a region of T2 signal, which is suggestive of acute edema in a patient of sarcoid, on top of regions of LGE. So indeed, LGE on MRI is a part of a major criteria to make a clinical diagnosis. This is the Heart Rhythm Society criteria from a few years ago that indicated that it's all about, not just about looking at LGE, it's about characterizing the pattern that is consistent with cardiac sarcoidosis. It's not a perfect rule, but the context of the patient and the pattern in combination is exactly is what's important. So this is a paper that recently characterized 50 patients who either died or had a heart transplant, so that MRI imaging was used to correlate against the pathological samples, and it's shown that there are different patterns in cardiac sarcoidosis that one can see, and again, it showed the many phases of cardiac sarcoidosis, the many patterns of myocardial involvement can be seen. often you can see an expansion of the wall thickness with infiltration of inflammation and sarcoid materials, and also involving multiple area. There are multifocal patterns as seen here. There are also a key common feature is that it involves the epicardium and so forth. In the more chronic stage, there are also areas where you can see a sort of a full thickness, thin out myocardium as shown here. RV involvement is known to be a high-risk features. So, based on this paper, there are several patterns that stands out that make the diagnosis of cardiac sarcoidosis more specific, such as epicardial pattern, multifocal pattern, especially involving the septum and involvement of the RV free wall. So again, the pattern of the LGE is not. It can be interpreted in some situation as non-specific, especially when there are patients with coexisting disease such as coronary disease that might have maybe confusing the picture. But often we see in clinical care, again, the context of the patient is the most important. If it's a high-risk patients with systemic sarcoidosis with a compatible history, and you see something like this, which involves the septum, expands the wall, clearly very bright, very focal, and that's that when you see something like that, there's not a lot of things that can explain other than cardiac sarcoidosis. So it depends on the pattern, but also in the context as well. Which, if you actually focus on the literature, I think the interpretation can be more specific. So that was diagnosis, but in terms of management of the patient, I think we have to look at the literature critically to see in what way cardiac MRI is actually helping with the management. So here's a paper from my group from a few years ago from Edward Houghton, who looked at, this is from 2016, and he looked at 7 studies at the time that comprising of almost 700 patients with suspected cardiac sarcoidosis. Most of these patients were patients with systemic sarcoidosis, and he observed an LGE prevalence, LGE in the heart, of about 30%. And by looking at this meta-analysis, one conclusion that could be drawn was that a presence of LGE is a high-risk marker in terms of all-cause mortality, cardiac mortality, arrhythmias such as VT or resuscitation by resuscitated VT or appropriate shocking, or arrhythmia-related death are markedly elevated in those with LGE, whereas an absence of LGE is in many ways a reassuring finding. This is an important point because it has implication of guiding the use of ICD in this challenging situation. An absence of LGE in this meta-analysis demonstrated a less than 1% annual risks of all these events if there is no LGE in the LV. Another paper that came around at the same time that also demonstrated the role of the way that cardiac MRI can be used. It cited that this is a paper that looked at a reasonably sized sample of about 300 patients who have systemic sarcoidosis, refer to their registry to look at cardiac MRI, echo, history, and every patient also have an EKG and Holter monitor. And they found that while they reported a high sensitivity and specificity in diagnosing disease by cardiac MRI, but of course, it's a little bit misleading because MRI is actually a part of the criteria. But to suffice to say, it's shown that the use of just symptoms and Holter, and even after you add a TEE and echocardiogram, the sensitivity and specificity is actually just not high enough. Echo can be very specific, but the sensitivity of echo alone is not high enough to detect these conditions. And it found that LGE, consistent with the meta-analysis, LGE absence is actually a favorable status in terms of heart outcomes for these patient groups. And this paper went on to describe how echo and MRI can be used in terms of cardiac symptoms and EKG abnormalities. In my center, basically, many of our clinicians have directly used cardiac MRI if there is any concern of cardiac involvement in patients with systemic sarcoidosis, be it symptom, be it EKG abnormalities, let's go right to MRI, because echo is really by itself, without the tissue characterizing ability, is lacking sensitivity. It's reasonable for those patients without any symptoms or EKG changes to monitor or be screened by an echo if it's negative by echo and Holter without any symptoms or any cardiac clinical concern. I think it's reasonable as a screening tool. But if there's any concern, I think it's reasonable to go straight to a cardiac MRI to increase your diagnostic yield. Now, the current AHA, the current HRS, the Heart Rhythm Society guideline for management of patients for consideration of ICD in patients with cardiac sarcoidosis are shown here. They listed class 1 and class 2A indications. Class 1, of course, are the high-risk patients, those who presented, those who have suspected, those who have systemic sarcoidosis and or found to have sarcoidosis on a subsequent investigation, who presented with VT or cardiac arrest or have a substantial LV dysfunction, EF less than 35%. Of those, these are very high-risk patients. That constitute a class 1 indication. But other than that, there are also 4 class 2A or reasonable indications for consideration of ICD. Those with more preserved EF either have syncopal spells, have scars by MR or PET, or have an indication for pacing, or who have inducible ventricular arrhythmias. It's reassuring to see that these criteria appear to be robust, at least for current clinical use. Why? This paper by Kazmersak and Shenoy et al. Looked at approximately 300 patients, 290 to be exact, and they found that it is true that if you go by the current indications, those with class 1 have very high event rate, therefore justify the use of an ICD. And those with class 2A, a majority of that are patients with more or less preserved EF, but was demonstrated to have MRI or MRIs or PET scar. They have a higher risk, even though the EF is somewhat preserved. They have a higher risk, and most reassuringly, those without any class 1 or class 2A indication, they did overall fairly well with no indication for ICD, and they behave favorably. So I think this is a paper that sort of validates the current guidelines, class 1 or class 2A guidelines. And when they actually look at the event rate of this classification, they further went on to conclude that a certain size of the LGE can be actually useful. So again, class 1 indication, those are the high-risk patients with event rate that are fairly high, up to 81% with those who presented with a ventricular arrhythmic event or sudden death, about 20% in those with a very poor EF. But even in the class 2A patients, those who needed pacemakers have about a 20% incidence rate of adverse cardiac event. But this paper further conclude that if they look at the those with an EF of more than 35%, but have some kind of scar, but if the scar size is actually more than approximately 6%, those are people who really can benefit the role of an ICD. And whether this is actually going to be further in clinical use, we'll see in the near future. Now, so there are several different papers from different groups have demonstrated, corroborated on how cardiac MRI can be prognostically important. This group also from the similar group of authors from the last paper also look at these approximately 300 patients, and they look at the pattern of RV dysfunction or RV LGE involvement, and what type of risks are they respectively corresponding to. And they found that those with RV dysfunction, dilated RV dysfunction or RV globally, had a prevalence about 12%, and they tend to have a higher cause of all-cause mortality, mostly related to RV pump failure, probably a reflection of the underlying pulmonary conditions. Whereas those with RV LGE, which happen in about 6% of the cohort, they are more prone to, again, consistent with the finding of the LGE in the LV, they're more prone to arrhythmic response, arrhythmic outcome, sudden cardiac death, or significant ventricular arrhythmias. So something to also learn that LGE involving the RV is a high-risk marker, and that should be a consideration for ICD. Mapping of MRI, such as by T1 or ECV mapping, have been shown, and also T2 weighted, as I've shown in one case, T2 weighted for edema imaging, as shown in this case here. You can see the bright spots is showing edema surrounding the area of LGE, suggestive that the tissue is somewhat edematous and swollen. And in T1 mapping, similar observation that shown that in patients with cardiac sarcoidosis, you can see the anterior wall being scarred, as in this case. The anterior wall has multiple area of fibrosis, but also the rest of the myocardium has foci that light up on T1 mapping and ECV mapping, suggestive of other scar pattern, and there's also a component of inflammation. These findings have been shown in several papers, but exactly how to use these and whether they are usable, they are good enough to scale the changes of myocardial inflammation, for example, secondary to steroids. These are not perfectly, these still need some more work, and they are still remaining at the investigational stage. So I think MRI is for the above reasons for diagnosis and for risk categorization, I think cardiac MRI is a reasonable initial test of choice, first test of choice, because of its simplicity and its ability and its high negative predictive value. And that's actually shown in the Journal of the ASNC criteria as published recently. I think MRI, as shown here, if in presence of LGE, I think is a strong indication to consider ICD. However, in terms of scaling for concurrent inflammation, FDG certainly is currently the most robust marker to scale inflammation, and it can be, and I think it's reasonable to obtain an FDG to consider the role of immunosuppressive therapy on top of the ICD. Well, I think there is still some work that needs to be done in terms of how FDG can truly monitor the change in inflammation and how to tie with the dosing and choice of immunosuppressive therapy. But I think it's a reasonable approach to start with the MRI and then consider for the role of FDG if one needs to give immunosuppressive agent. If the MRI is negative, I think is reassuring. You don't have to go on to have further testing. So T2 mapping can also show edema or active inflammation. However, there's limited data on this as of now. And FDG by PET is a more sensitive and a marker for inflammation than T2 mapping, and is recommended to guide immunosuppression. So as I mentioned, I think that MRI positions itself as an excellent test of choice as the first test, as the initial test, based on its very good negative predictive value, and it can also identify other cardiomyopathies. And in general, it is simpler to do than FDG PET as the first test. So in conclusions, cardiac MRI for cardiac sarcoidosis is excellent for making the diagnosis of cardiac sarcoidosis. It should be the initial test of suspected cardiac sarcoidosis for both diagnostic and risk stratification of ICD. It is reliable to guide ICD placement given its low incidence of arrhythmic events and mortality of patients if there is no LGE. But again, the context of the patient is important. The pattern of the LGE and size are both important. FDG PET, however, is preferable to guide immunosuppression. Thank you very much for your attention.
Thank you, Dr. Kwong, for that very interesting and exciting presentation. It is now my pleasure to introduce Dr. Edward Miller, who will be presenting on the role of PET-CT in cardiac sarcoidosis. Dr. Miller is currently an Associate Professor of Medicine and Radiology and Biomedical Imaging at Yale University Medical School, where he is the Director of Nuclear Cardiology at the Yale New Haven Hospital and Health System. As well, he is the Director of the Cardiovascular Medicine Fellowship Program. Dr. Miller?
Thank you for the opportunity to talk about the role of FDG PET-CT in cardiac sarcoidosis. I'm Ed Miller from Yale. These are my disclosures. So it's a really exciting time in cardiac sarcoidosis, particularly in understanding the role of cardiac imaging in the evaluation for diagnosis, prognosis, identifying those who respond to therapy and following that therapy. And obviously the other participants in this session will discuss the other modalities, particularly cardiac MRI and its role in cardiac sarcoidosis. I'll focus on the role of FDG PET with myocardial perfusion imaging in the evaluation of cardiac sarcoidosis. So really there are four main scenarios where FDG PET for cardiac sarcoidosis makes sense. The first is obviously in those patients who have suspected cardiac sarcoidosis, or for whatever reason, whether it's a cardiac implanted device or impaired renal function, cannot get a cardiac MRI. Or alternatively, in those patients who've already had a cardiac MRI that shows findings suggestive of cardiac sarcoidosis, such as late gadolinium enhancement, identifying scar, where you want to know whether there's active disease or active myocardial inflammation. The second common scenario, and the most highly accurate common scenario, in my opinion, is those patients who have a presentation with acute high-grade AV block where you're concerned about acute myocardial inflammation. Another important role is the evaluation for extracardiac sarcoidosis because the determination of extracardiac disease is so important in the evaluation for the overall likelihood of cardiac involvement. And lastly, we use FDG PET very frequently to understand the need for immunosuppression and importantly to monitor the response to immunosuppressive treatment. Many of the things I'm going to be talking about today, including the complementary use of FDG PET and cardiac MRI, which will be discussed by other speakers, are codified in procedural guidelines, as you can see here, that were published in 2017, talking about the preferred use of CMR and FDG PET in cardiac sarcoidosis. In particular, as you can see, the role for FDG PET in patients who've had an abnormal CMR or who can't get a CMR, or in those patients where immunosuppressive treatment is being considered. The complementary role of cardiac MRI and FDG PET was very nicely delineated by the Brigham group, as in this paper by Vida et al., where they looked at the enhanced role of both cardiac MRI and FDG PET findings for the determination of the likelihood of cardiac sarcoidosis. I won't get into the specifics of this study other than to say that frequently these two imaging methodologies are additive and not and shouldn't be individually applied to the patient with suspected cardiac sarcoidosis. Before we talk about FDG PET for cardiac sarcoidosis and the indications, we need to understand that there are certain performance and interpretation standards that need to be met. The first is suppression of endogenous myocardial glucose uptake. As you know, the heart is a metabolic omnivore. It can use various fuels to generate energy. But we're looking to suppress endogenous glucose uptake in order to identify infiltrated macrophages that are particularly glucose avid in the setting of myocardial inflammation. To suppress myocardial glucose uptake, our preferred method is a prolonged fast, usually over 12 hours. It's very simple. We schedule our studies for the late morning usually. What we watch out for, though, are patients who may be getting sugar as part of their medical treatment, particularly those inpatients who are on dextrose infusions that can occur with IV magnesium, IV amiodarone, etc. It's not unusual for us to have a study rescheduled because a benevolent intern ordered a gram of intravenous magnesium, not realizing that it came in 5% dextrose solution overnight. In addition, acute heart failure itself can change the metabolic milieu and decrease the specificity of FDG PET imaging. Recent ablations, cardiac device implantations, etc., can also cause myocardial inflammation and should be avoided in the acute setting prior to FDG PET imaging. Other diets, such as the high-fat, low-carbohydrate meals prior to imaging, and heparin can also be utilized in certain scenarios to improve endogenous myocardial glucose suppression. It's also important to understand that one needs to interpret FDG PET imaging in a specific way. FDG PET, as opposed to myocardial perfusion imaging, is a hotspot imaging technique. Myocardial perfusion imaging is a cold spot technique where we're looking for the absence of counts. FDG PET imaging, we're looking for the increase in FDG avidity over baseline. So in these scenarios, we need to use a display convention that accounts for this ability to track absolute changes in activity relative rather than the relative changes that one sees in the commonly used cardiac display conventions. When we display FDG PET imaging, as in this case example, in the top row, we have myocardial perfusion imaging with rubidium. In the second series, we have FDG PET imaging showing focal uptake in an area of a perfusion defect. We can see that in common scenarios, it's relatively easy to identify focal areas of FDG uptake in areas of myocardial perfusion abnormalities. And this is a highly probable case for cardiac sarcoidosis. However, one should use extreme caution when interpreting studies solely using standard myocardial perfusion imaging software. And I show this example where I've just changed the contrast or the gain in the images from a single image, showing that one can adjust the image intensity without changing the absolute tracer uptake and make studies look completely negative or something closer to positive. And so this normalization artifact is critically important and should be absolutely avoided when one interprets FDG PET imaging for cardiac sarcoidosis. In our laboratory, we routinely use and have the standard of using fused FDG PET imaging, axial fused imaging from a hybrid imaging workstation set to an SUV scale of around 0 to 7, 0 to 5, 0 to 7 grams per ml is usually appropriate to identify those areas of FDG imaging that are abnormal. You can see in this case, there's very slight abnormalities in the lateral wall of the septum. But what we can also see is areas of FDG. We can also see the morphology of the lungs, the morphology of the heart, etc., right ventricular structures, hilar lymph nodes, which are critically important to the identification of overall sarcoidosis burden. We've been an advocate for SUV threshold quantitative interpretation, and we use an LV blood flow quantitative threshold to define the background values for FDG uptake, and then create a volumetric measure of abnormal FDG signal, in particular focusing on the area of cardiac SUV max, or the maximal intensity pixel in the heart. We've shown that these interpretive methodologies are important and can potentially reduce unnecessary interventions. In a retrospective analysis of 130 patients at our institution before we used the quantitative approach, when we look at those studies using quantitative approach, we found that 15 patients were potentially mischaracterized by the visual methodologies. 4 of those patients had ICDs placed after a study that we thought was negative but was read as positive. And 11 of those patients had prednisone increased or other immunosuppressives started based on the results of those studies. So it's critically important, we think, to read FDG PET imaging with a high degree of specificity. One other cautionary note about FDG PET imaging is a study we performed looking at the reproducibility of this technique. We found that in 15 patients with high likelihood of cardiac sarcoidosis, we tried to repeat the image within 2 weeks without a change in medication and using the same dietary prep with strict adherence by the patient. We did dietary prep coaching and validation and had the patient do a food diary and phone calls. What we can see in these images of nice reproducibility, that in scan 1 and scan 2, that there was usually good reproducibility. And when you look at the metabolic markers, we measured insulin, free fatty acids, and glucose. The dietary prep was consistent and led to consistent metabolic values. So here in this example, a negative example, was negative again 2 weeks later, and negative with a longer incubation time of 120 minutes. Similarly, with a positive example here on the bottom. However, in 4 of our patients, we got dichotomously different results on the second scan. You can see here a negative scan that goes to positive, a positive scan that 2 weeks later goes to negative, and similarly down the line. So this argues that that FDG PET imaging has issues that we know about with regards to reproducibility, and we should be looking for new tracers in the future. So let's go through some specific scenarios. The evaluation of high-grade AV block is a particularly important one. This is a case we published in JNC last year, where a healthy 45-year-old female presented with acute heart block. She was from Connecticut, so her Lyme serologies were negative, otherwise a normal exam. As you can see on the FDG image, we have a very focal area of FDG uptake in the crux of the heart, in the area of the AV node, along with identification of FDG avid lymph nodes. These were subsequently biopsied and showed to be non-caseating granulomas. What's interesting in this case is we were able to do some dedicated 3-dimensional T2 sequences through the AV node on CMR and found that there was areas of late gadolinium enhancement in that region as well. And this idea that there is focal areas of FDG uptake in patients who present with complete heart block was shown by these patients, by this group out of Japan, that showed that patients who had complete heart block positivity on their initial exam were more likely to have FDG uptake in the interventricular septum. Another important case is the evaluation for extracardiac sarcoidosis. I'll show you a case of a 53-year-old woman who had a history of conduction disease and a pacemaker implanted for what was thought to be idiopathic conduction disease in the past. She previously had a normal chest X-ray and normal echocardiogram, but on a device interrogation was found to have ventricular tachycardia, which was asymptomatic. We can see here on this maximal intensity movie, as well as on the axial images of the emission, fused, and transmission scans, we can see that there are obviously FDG avid lymph nodes in a pattern consistent with sarcoidosis. Now, what's interesting is on this attenuation correction CT, those lymph nodes did not appear to be pathologically enlarged. So the use of FDG PET imaging really changed the management here as she was biopsied and showed they have sarcoidosis, unifying her total diagnosis. Another case of a 72-year-old woman who'd had idiopathic VT and palpitations on a monitor 2 years prior. At that time, an extensive workup was essentially normal and no more VT. However, she did have some chest imaging which showed a left upper lobe pulmonary nodule. Because of that nodule and a concern for cancer, she underwent a whole body FDG PET scan for evaluation for oncology for cancer. As you can see on this axial fused image as we scroll down, we'll see in the left upper lobe here of her lung, she had an FDG avid nodule and mass, which she underwent resection for because of concern for cancer. It was found to have non-caseating granulomas, again unifying the diagnosis. The idea of using FDG PET imaging to identify areas for biopsy for mediastinal lymph nodes and extracardiac sites was demonstrated in this group from Finland, who showed that it's frequently the diagnostic yield of using FDG PET imaging can be quite important. The need for immunosuppressive monitoring and treatment is an important use of FDG PET imaging as well. But there are big questions in our treatment for cardiac sarcoidosis. We don't really know who needs treatment, whether it's everybody or just those patients who have systolic dysfunction. Should we be using it for all patients based on their presentation? Certainly those who have AV block tend to respond better than those who have ventricular arrhythmias. In my opinion, we should only be using immunosuppression in those patients that we can document myocardial inflammation, such as by FDG PET imaging, rather than using it in patients who might have scar-only disease or burnt-out disease identified at cardiac MRI. But we still don't know what patients should be treated in terms of how they should be treated with steroids or steroid-sparing agents, how long, and how that treatment response should be assessed. There's arguments for and against using clinical endpoints versus imaging, in particular FDG PET imaging. So here's a nice example of treatment response. Again, this is a maximal intensity projection. As you can see there of the thorax, of cardiac field of view, you can see there are multiple focal areas of FDG abnormality in this patient, who is then put on steroids for prednisone of 30 milligrams a day for 3 months, and repeat the imaging. And as you can see, the FDG signal melts away. And this is a pretty uniform or standard response to immunosuppressive treatment in most patients. And we've shown that quantitative interpretation can reliably reduce FDG or show a reliable reduction in FDG signal using different markers, whether it's metabolic activity or volume or SUV max, and that there is some rebound phenomenon when one stops immunosuppression or reduces it. This data has led us to propose a 3-PET approach to the treatment of FDG, of cardiac sarcoidosis, one where the initial need for immunosuppression is defined by the initial PET scan. A second scan is performed while on maximal treatment to look for maximal intensity response, and a third scan performed after reduction of immunosuppression to ensure the rebound phenomenon hasn't occurred. So it's our opinion that some patients with cardiac sarcoidosis likely benefit from immunosuppression, and thankfully there are a couple of randomized trials in this area that are currently enrolling to study the role of immunosuppression in patients with cardiac sarcoidosis. These trials are based on the idea from meta-analysis such as this one that there are potentially some benefit in selected populations for corticosteroids for patients with cardiac sarcoidosis, particularly in those who have a moderate reduction in systolic function. And those who respond by SUV metrics, as shown by the Brigham group here, those who respond with a reduction in FDG signal tend to have an increase in their systolic function. So at present, my other opinion is that FDG PET probably represents the best current method to measure immunosuppressive treatment in at least in initial phases in cardiac sarcoidosis, realizing that the monitoring of long-term immunosuppressive therapy is not clear. So sort of in summary, the guidelines suggest that we use FDG PET in the following fashion. One is if it's positive to guide immunosuppressive treatment, and then to repeat the study to establish treatment response. And if the reduction is not sustained or significant, then consider changing or adding and modifying the immunosuppressive treatment. In my last data slide here, the JNC, JNM, SNMMI guidelines succinctly describe the scenarios that I've laid out for the use of FDG PET imaging. Those who have histologic evidence of extracardiac sarcoidosis, such as abnormal cardiac MRI findings, may benefit from FDG PET imaging. Young patients with unexplained heart block, patients with ventricular tachycardia that's otherwise undefined, and those with proven CS as an adjunct to follow clinical response to treatment. So at this time, I'd like to thank my colleagues at Yale, those of us in the Cardiac Sarcoidosis Clinic and the Nuclear Cardiology Lab who contributed to this work, including current and former trainees. Thank you very much.
Thank you, Dr. Miller, for that excellent overview on the applications of PET-CT in cardiac sarcoidosis. It is now my pleasure to introduce Dr. Ronald Wittlis, who will be presenting on how a cardiac sarcoidosis specialist integrates multimodality imaging. Dr. Wittlis is Professor of Medicine and Cardiovascular Medicine at Stanford University School of Medicine. He is co-director of both the Stanford Amyloid Center and the Stanford Multidisciplinary Sarcoidosis Program. He serves as the program director for the Internal Medicine Residency Training Program. He is an associate editor for the Journal of the American College of Cardiology, Cardio-Oncology Journal. Dr. Wittlis.
Hello, my name is Ron Wittelis. I'm professor of medicine at the Stanford University School of Medicine, and among other roles, I am the co-director of the Stanford Multidisciplinary Sarcoidosis Program. It's my honor and privilege to be here today to deliver this talk, and my topic is how a cardiac sarcoid specialist integrates multimodality imaging. Well, if we start with some of the basics, sarcoidosis is an inflammatory disorder of non-caseating granulomas, which can involve any organ. If we focus on the cardiac clinical features, there's several. Heart block and ventricular tachycardia are very common arrhythmias. LV dysfunction is quite common, usually segmental. And there's, interestingly, a lack of a significantly elevated troponin. It can sometimes be detectable, but it's not significantly elevated most of the time, as you'll see in other infiltrative cardiac diseases or myocarditis. When we're diagnosing cardiac involvement, endomyocardial biopsy, though, the gold standard is quite low yields. And you can increase it with voltage map guided biopsies, but even there it's fairly low and really requires great technical expertise. Cardiac involvement can occur alone or with extracardiac involvement. Most commonly it is with extracardiac involvement, but it certainly can be alone. And it was clearly underdiagnosed before recent imaging advances, but I would argue that it is now simultaneously overdiagnosed due to false positives. So let's talk about the imaging. When we look at the criteria for diagnosis, the first major ones were put out of Japan in 2006, and I'm not going to read through them all, but I'm going to highlight that you had to either have the myocardial biopsy, which I just highlighted some of the problems with, or you had to have a concomitant diagnosis of extracardiac sarcoidosis. In addition, there was a big emphasis placed on having a positive gallium scan, which at the time was the main imaging, but has really quite poor sensitivity and has now been really replaced by FDG PET. So the Heart Rhythm Society updated these criteria in 2014, as we see here. And though, again, I'm not going to read through them all, I want to point out that once again, you either have to have a positive myocardial biopsy or you have to have extracardiac sarcoidosis that's proven. In fact, in the Heart Rhythm Society criteria, it had to be a histologic diagnosis. Well, this leaves us with the large problem, which is that we still have no pathway of making the diagnosis in patients who don't have extracardiac disease. And given that we know that cardiac isolated disease can occur and that the yield of myocardial biopsy is quite low, this is a real problem and it's going to clearly lead to underdiagnosis. But if we go too far the other way and use imaging too liberally to make the diagnosis without biopsy, we risk overdiagnosis. So, well, what to do? Well, when we look at our imaging options, we have several. Well, echo is, of course, the most common to be performed. It's going to be usually obtained already in any patient where there's suspicion. There's no ionizing radiation, but the problem is wall motion abnormalities are really not at all specific for sarcoid, and it definitely can't differentiate between active disease and scar. So that brings us to MRI. MRI has some advantages. If you don't see any abnormal delayed gadolinium enhancement in a high-quality scan, the chances of cardiac sarcoidosis being a diagnosis is really quite low. In addition, there are sequences that can suggest edema, though I'd say these are less reliable and validated. And of course, there's no ionizing radiation. But there's real disadvantages too. It doesn't differentiate well between sarcoidosis and other diseases that are causing scar. It doesn't differentiate between active sarcoid and old scar, burnt out disease. That's a real negative, as we'll see. There's challenges with imaging patients with pacemakers or defibrillators where either you just can't image them or the image quality may be impaired. And of course, it's not as widely available as some other things with variable availability and expertise. Which brings us to FDG PET imaging, which has some real advantages. It's widely available. It can differentiate active disease from burnt out disease, which is really useful, not just for diagnosis, but then for monitoring and titrating therapy. There's no issues with pacemakers and defibrillators. And really importantly is that it can give a full body scan, not just the heart, as we'll come back to. There's some real potential pitfalls besides the obvious ionizing radiation. It's not specific for sarcoid. It really just says there's inflammation, but maybe we don't care. If there's inflammation, we probably want to treat it. If the diet is not meticulously followed, it becomes a largely worthless test. And this is really the Achilles heel of FDG PET imaging. And the findings can be obvious or subtle. If you see no uptake at all or focal hotspots, it's really useful. But how about other patterns? We'll look at those in a moment. I would say always look at the scans yourself. From my experience, there's great variation in the reads, not only inter but intra-institution. So we all know what the biggest epidemic of 2020 is, but I'm going to argue that, at least in my world, the second biggest epidemic is this, the false positive sarcoid PET scan. And I see this a ton, and the reason is usually the diet. So this is one approach. There's several that have been described about how to do proper dietary prep for a patient undergoing a sarcoid protocol FDG PET. The key is they have to meticulously follow a no carbohydrate diet. How long? That's debatable. I say at least 24 hours. The longer the better to ensure a high quality scan. So here's my approach when I'm seeing a patient with newly suspected cardiac sarcoidosis. Question one, how strong is the clinical story? If it's a really strong story with classic heart block, ventricular tachycardia, wall motion abnormalities without coronary disease, I'm going to be much more likely to believe the scan results that are positive than if it's a softer story and a equivocal scan. Are there alternative explanations like I've shown up there? There's many different diseases that can cause some of these findings. Then the key is to integrate the imaging findings. So if you see an area of delayed gadolinium enhancement on MRI that matches up perfectly with a hotspot on FDG PET, that is really likely to be true inflammation. Or if you see focal wall motion abnormalities without coronary disease, that again matches up perfectly with the FDG uptake, really suspicious. Are there classic signs of extracardiac uptake, as you see in the scan in the upper right? So if you don't see any extracardiac uptake, you should be inherently suspicious of the diagnosis, because though isolated cardiac sarcoidosis does occur, it's the exception. Most of the time there is extracardiac sarcoid. So if I don't see any, it makes me immediately suspicious of a false positive. And then what's the pattern of the cardiac uptake? And here's some patterns of involvement from an article we published out of Stanford last year. The really useful ones are A and C. Clearly negative in A and certainly looks positive in C. But things like B, where you just have diffuse uptake, that's non-diagnostic. F is just poor preparation. Again, you should not read anything into that. The really challenging one is D. Is this a positive scan that's sort of patchy on diffuse, or is this a false positive? Honestly, it could be either one. Well, how about using PETs to follow up a patient who has confirmed or probable diagnosis? Well, there I really look at what happens to extracardiac uptake along with what happens to the heart. Because if the extracardiac uptake has melted away, but the heart hasn't changed or maybe has increased, I'm going to be suspicious that what we're seeing in the heart, again, is a false positive. Versus if they're going in the same direction, you're much more likely to believe that it's true. I also look at the pattern of cardiac uptake. Is it in the same spots as before? It's unusual for sarcoid to be hot in one area and then completely disappear from there and be hot in another area. It technically can happen, but it's not the typical pattern. So the more consistency you see in the locations in the heart, the more likely you should believe that it's real. So here is our approach at Stanford with imaging. So first is clinical suspicion is typically raised by the patient's clinical scenario and then the echo or MRI findings. Number two, as long as we can get a diagnostic, a high quality PET scan, then that's our primary imaging technique to then follow the patient's disease. And we get several over the first 6 to 12 months as we're titrating the immunosuppression, with the goal of trying to get them to the lowest possible dose of immunosuppression possible, certainly from a steroid perspective, but have the disease under control. Once we've done that, we don't keep getting serial PETs because we want to be thoughtful about the radiation exposure. And we will only get it at that point if there's a clinical reason to be suspicious. How about treatment? Well, that's a big topic, but I'll just touch on a couple of the basic principles. It's always that balance of overtreatment versus undertreatment. And specifically, we want to treat active but not burnt out disease. My goal is to get patients off of steroids, ideally, or at least on a very low dose, and on a maintenance steroid sparing regimen. And usually our first go-to is methotrexate. So up front, we will start most patients on a combination of steroids and methotrexate, get another PET scan to prove that the disease has gone away, the active disease. And then we're going to wean down the steroids as we wean up the methotrexate, follow PET scans along the way. What if that's not enough or they don't tolerate the methotrexate? Then we look at other options, in particular TNF inhibitors, which I'm going to speak about. So this is my usual protocol. There's no clear right and wrong answer on this. There's no good evidence one way or the other, but this is how I usually manage the patients. I'll start them on prednisone. You see the range. I usually go on the lower part of that range, often 30 or 40 milligram of prednisone. I'll start methotrexate up front, as you see, with the typical monitoring pathway, and then we'll wean. And again, the goal is to get the methotrexate up to maximally tolerated doses of 20 to 25 milligrams per week. And we'll repeat those PET scans every couple of months as we are weaning the prednisone. Don't forget, of course, about prophylaxis for PJP, osteoporosis screening, et cetera. Well, this was an interesting study that recently came out asking how much prednisone should we use and for how long. So again, there's really not good evidence to guide this. So in this report, the investigators looked at 32 patients who had cardiac sarcoidosis with positive FDG PETs. And it wasn't randomized, but they said, well, what happened to the scans for patients who got higher versus lower doses of prednisone? And what happened for patients who got longer versus shorter bursts of the prednisone? And what they found was there was no association between the prednisone dose up front or the long versus short time with the FDG PET scan changes. And it suggests maybe we're over-treating some of these patients up front. How about TNF inhibitors? Well, unfortunately, there's still a stigma with TNF inhibitors and not using them as much in patients who could benefit because of this trial, Renewal, which was a study of the TNF inhibitor etanercept, looking at its use to actually try to help patients with heart failure in general, not sarcoid, just heart failure in general. It wasn't effective. In fact, there was a slight trend towards worsen outcome, not statistically significant, but somehow that result has been translated into you can't use TNF inhibitors in patients with heart failure. That is flatly false. And in fact, for patients with cardiac sarcoid, they can really be very useful. Here's a study that we published with 77 patients who had cardiac sarcoidosis. You can see how they presented on the left, and you see the medications they got on the right. And though prednisone and methotrexate were the two most common, third by far was TNF inhibitors. And when we looked further into what happened in the patients who used TNF inhibitors, almost all patients had their prednisone dose come down, many got to 0, and their left ventricular ejection fractions tended to stay the same or get better. Here was another recent study. This is 38 patients treated with TNF inhibitors across 2 institutions. And you can see similarly in the upper graph, the prednisone dose came down significantly with time. And on the lower graphs, you can see what happened with the imaging. So on the left, you see the number of segments that were positive on FDG PET dramatically better after the TNF inhibitor. In the middle graph, you can see the mean SUV max for patients pre and post TNF inhibitors. Again, massively better. And we've seen certainly similar findings at our institution. How about other cardiac therapy? Well, there's no good evidence to guide with this. Standard heart failure therapy in patients with LV dysfunction seems like a good idea. We usually do it, but again, there's no good evidence. I would just caution, be careful about using beta blockers in this population if they don't have a pacer or defibrillator because heart block is so common. Transplant can be an option if a patient needs it and they are otherwise a good candidate. Rhythm management is really important. Sometimes antiarrhythmics are needed. VT ablation can be a useful adjunct, but generally you're going to want to wait till you have properly immunosuppressed them before doing, because sometimes the immunosuppression alone will make the VT go away. And then device placement, you want to have a really low threshold for pacemaker or defibrillator. And in fact, Heart Rhythm Society says as a class 2A recommendation that any patient who needs a pacemaker anyway, who has cardiac sarcoidosis, should just get a defibrillator. And that's our practice as well. This was a patient example from our manuscript from last year, and it's, I think, instructive. So just to go through what happened, this is a 57-year-old man with biopsy-proven pulmonary sarcoid who presented with new ventricular tachycardia and heart block. And you can see the scan in the upper left. It gets at the classic problem, clearly positive in his lymph nodes and lungs, but the heart was really non-diagnostic when you look at the image. But between his known diagnosis and the presentation, we thought that was enough evidence. We started immunosuppression. And you can see what happened with his scans over time. He had a small area of hotspot on the second scan, and then it was gone by the third. And as we weaned the immunosuppression, it stayed negative, and then on the second to last scan, you see there on the bottom, the disease recrudesced because we'd gotten him just about off of prednisone. So at that point, we didn't want to leave him on substantial doses of prednisone for the long term. We put on the TNF inhibitor infliximab, and that completely controlled the disease, and he continues to do well now years later. So in summary, for integrating multimodality imaging, you want to think about cardiac sarcoid in a patient with heart block, VT, or low ejection fraction, in a patient with extracardiac sarcoid, or when you have a clustering of two of the above without a good explanation. Think about the disease. My approach is to integrate cardiac imaging in the diagnosis, but we'll typically use FDG PET as our main entity to monitor disease activity. But you have to be aware of that false positive scan with all the caveats that we went through. In terms of other cardiac management, again, rhythm management is important, and we tend to put on standard heart failure therapy when it's indicated. For immunosuppression, the goal is to suppress the disease activity with the least immunosuppression possible. And I use methotrexate pretty much in everyone. But as I highlighted, there's really clearly seems to be a growing role for TNF inhibitors. And finally, I'll just say this is a disease that really requires close multidisciplinary collaboration. We have a wonderful team that I'm privileged to work with at Stanford. Feel free to contact me with any questions, and I thank you for your attention and your interest.
Thank you, Dr. Willis, for sharing with us how a true cardiac sarcoidosis specialist integrates multimodality imaging. Very insightful for our imaging audience. I'd now like to introduce Dr. Robert Miller, who will be presenting cases focused on cardiac sarcoid. Dr. Miller is an assistant professor in the Department of Cardiac Sciences at the University of Calgary, and he is the medical director of nuclear cardiology and cardiac CT program. His research interests include advanced cardiac imaging applications in patients with cardiomyopathies, as well as epidemiology in heart failure and cardiac transplantation. Dr. Miller.
Hello, everyone. Thank you for listening in. My name is Dr. Robert Miller. I'm a clinical assistant professor at the University of Calgary and live in Cardiovascular Institute of Alberta. I'm going to be presenting a talk entitled Cases in Cardiac Sarcoidosis. I'd like to start by thanking the organizing committee for inviting me to give this talk to you. In terms of disclosures for this talk, I don't have any relevant disclosures. I am a heart failure cardiologist who also has an active practice in advanced cardiac imaging. And again, you can see my affiliations with the Lehman Cardiovascular Institute and the University of We'll start right off with the cases. The first case is a 61-year-old gentleman with a history of pulmonary sarcoidosis. His original diagnosis was made 5 years prior to us seeing him in clinic. He was diagnosed on the basis of characteristic CT scan findings as well as abnormal pulmonary function tests. He was treated with a course of corticosteroids with good improvement in his initial symptoms. He was referred to us with a specific question of whether or not he had cardiac sarcoidosis. At that time, he was having increased dyspnea for about 2 months. So at baseline, he was able to walk greater than 10 blocks without any shortness of breath. Currently, he was short of breath after about 1 block. We called him NYHA class 3. He denied significant orthopnea or PND, but he did have worsening cough for about 4 weeks. And he reported his cough was significantly worse whenever he lay flat. He denied palpitations, pre-syncope or syncope. The remainder of his cardiac review systems was negative. He was really referred to us on the basis of an outside echocardiogram that demonstrated low normal LV function with an LV ejection fraction of 50% and no regional wall motion abnormalities. His exam was significant for heart rate of 71, blood pressure of 110 on 76. He had scattered crackles throughout the lung fields bilaterally. There was minimal peripheral edema, and his JVP was normal at 3 centimeters above the sternal angle with negative AJR and no S3. The remainder of his cardiac auscultation was normal. We referred the patient for a cardiac MRI to better characterize his myocardium. So what you can see here are 2 cine images. There's SSFP sequences. So on the left, you have a 2-chamber. On the right, you have a 4-chamber view. You can see that the LV function was quite good. So it was reported as low normal, LV ejection fraction of 51%. His RV was reported as mildly decreased function with RVEF of 42%. There weren't any significant regional wall motion abnormalities that we could identify. The patient did have late enhancement performed. So here is a SSP sequence that's just a still shot of the mid-short axis to give a sense of how thick the walls were. Over here is the late enhanced sequences, which is a bit more basal on the short axis. But what you can see is that there's patchy mid-wall fibrosis that involved the basal septum, a lateral wall, and the RV insertion. Overall, the cardiac MRI again was reported as low normal LV function, LV ejection fraction of 51%. RV was mildly decreased at 42%. He had myocardial T1 mapping performed, which was normal for our scanner at 970. He also had T2 mapping performed, which was 50.5 for the average, without evidence of regional increases. So again, that was reported as normal. So the major finding from the cardiac MRI was the late enhancement, with the patchy mid-wall late enhancement in the basal septum and lateral wall, involving 8% of the myocardium overall. We went on to refer the patient for a FDG PET study for cardiac sarcoid. So these are the FDG images. What you can see is that the patient was well prepped for the study, and there's suppression of the normal myocardial metabolism. And there were no focal areas of myocardial hypermetabolism identified. What was identified on the study was increased uptake in hilar and mediastinal lymph nodes bilaterally, as well as new lung nodules on the CT, which were also FDG avid. The patient did have a rubidium resting perfusion study that was performed, and there was a mild defect in the basolateral wall that was consistent with the area involved most by late enhancement. So in terms of the question that was posed to us, whether or not the patient had cardiac sarcoidosis, we said that the patient probably had previous cardiac sarcoidosis. And that was based on the late enhanced findings, as well as the perfusion abnormality on PET. But we also said that we didn't think it was currently active, and that was on the basis of the normal T2 mapping, as well as the FDG PET images. Importantly, the FDG PET did identify hilar lymphadenopathy that was FDG avid, as well as new lung lesions that were FDG avid. The patient also had worsening PFTs and was started on pulse steroids by respirology with good improvement in his symptoms. So we hope that this case highlights how PET and cardiac MRI can be combined to give good data in terms of the presence or absence of active or inactive cardiac sarcoidosis. Our second case is a 57-year-old gentleman with a history of known cardiac sarcoidosis. So the diagnosis was made 2 years prior to his current presentation. It was made on the basis of a myocardial hypermetabolism by FDG PET, unexplained decrease in his LV function, and a supraclavicular lymph node biopsy that demonstrated non-caseating granulomas consistent with sarcoidosis. The patient's initial LV function was moderate to severely reduced with an LV ejection fraction of 34%. It was started on a combination of heart failure medical therapies as well as immunosuppression. That included an ACE inhibitor, beta blocker, and mineralocorticoid receptor antagonist, as well as immunosuppression with a course of prednisone and azathioprine. During his initial investigations, he had an episode of unexplained syncope for which he received an ICD. With medical therapy, his ejection fraction improved to 54%, but he was left with mild RV dysfunction. He was maintained on azathioprine and weaned off steroids. And following his wean from corticosteroids, he had an FDG PET study that was performed to assess for evidence of active disease. This is the FDG PET study. So again, the patient was well prepared and there was suppression of the normal myocardial metabolism and no evidence of focal myocardial hypermetabolism. We were now seeing the patient 2 years after his initial diagnosis. And in clinic, he was complaining of new onset of palpitations as well as worsening dyspnea. His shortness of breath had improved to the point that he was NYHA class 1, but in clinic he was reporting NYHA class 2 symptoms. We did perform an ICD interrogation that showed paroxysmal atrial fibrillation, but no episodes of treated VT and no AV block. The patient reported good compliance with his heart failure medications, also good compliance with his low salt diet. The patient also reported 2 weeks of orthotomy. On exam, the patient's heart rate was 64, blood pressure 98 on 52. The test was clear bilaterally. There was minimal peripheral edema, but his JVP was elevated at 6 centimeters above the sternal angle with positive AJR. There was an S3, no S4, but a 2 out of 6 holosystolic murmur along the left lower sternal border with respiratory variability consistent with bicuspid regurgitation. We arranged for the patient to have a repeat transthoracic echocardiogram shortly after clinic that showed a reduction in his LV function to 40%, moderate RV dysfunction, and moderate tricuspid regurgitation. Although we were highly suspicious for cardiac sarcoidosis recurrence, we were unsure if the patient's atrial fibrillation had caused the new decompensation in heart failure or vice versa. So we arranged for the patient to have an FDG PET study to assess for recurrence of cardiac sarcoidosis. So this is the FDG PET study. So again, what you have here is a 4-chamber view, or 2-chamber view, and a short axis in the basal area. You can see the patient was well prepped for the study. There's suppression of the normal myocardial metabolism, but there was a focal area of hypermetabolic activity in the basal, anterior, anteroseptal, and septal segments. And this was reported as highly consistent with cardiac sarcoidosis. The patient also had a resting rubidium study performed that demonstrated a perfusion defect in the same location. So he had a matched perfusion defect with hypermetabolism. Based on the PET study, the patient was diagnosed with a recurrence of his cardiac sarcoidosis. He was restarted on steroids, and his azathioprine was switched to methotrexate. He then had a repeat PET scan performed after 3 months of increased immunosuppression. And the repeat PET study demonstrated resolution of the myocardial hypermetabolism. Interestingly, the perfusion also improved. Importantly, the patient's atrial fibrillation burden decreased during follow-up, and his symptoms of dyspnea improved. So we believe this case highlights the potential role for FDG PET in monitoring response to therapy as well as longitudinal management for these patients. I want to thank everyone for listening to this talk today. If you have any questions, feel free to reach out to me. My email address is robert.miller@ahs.ca.
Thank you, Dr. Miller, for those very, very interesting cases, very insightful and excellent opportunities to learn how we approach patients with cardiac sarcoidosis. This has been a very, very exciting session, very educational. I've learned a lot myself, and I look forward to the next MOD session. Thank you, everyone, for joining us.